Imagine you are an eye doctor. Your decision can save a patient's vision. And you are using AI to help you make this decision. However, the AI tells you just yes or no. And it doesn't provide any reasons or show where the problem exactly is. Would you trust this? This is the black box problem in medical AI. Even though there exist many machine learning models to diagnose diabetic retinopathy, they are not used by the medical personnel due to weak explainability and lack of understandability. Welcome to Fantastic Datasets and Where to Find Them. In this video we will talk about MAPLES-DR dataset. MAPLES-DR stands for Mesidor Anatomical and Pathological Labels for Explainable Screening of Diabetic Retinopathy. This dataset advances in solving the black box problem by increasing the explainability of the screening models. It provides pixel-level segmentations, expert annotations, and clinician vocabulary by annotating data for 10 biomarker classes. By using this dataset, the screening models can not only classify diabetic retinopathy but also show where the problem is, thereby helping bridge the explainability gap in diabetic retinopathy screening. First, let us understand diabetic retinopathy. It is a complication of diabetes that affects the eyes. It occurs when chronically high blood sugar levels damage the tiny blood vessels in the retina. In some cases, it can lead to further complications called macular edema. Macular edema is a swelling or thickening of the macula, caused by fluid leaking from damaged retinal blood vessels. If left untreated, it can lead to irreversible vision loss. However, with early detection one can prevent vision loss. The MAPLES-DR is available as a Figshare dataset. It provides diabetic retinopathy and macular edema grading, along with pixel-level segmentation for 198 retinal images of the Mesidor public fundus dataset. What is segmentation? Segmentation is dividing an image into meaningful regions and assigning a label to each one. In pixel-level segmentation, a label is assigned to each pixel. In MAPLES-DR, each image is annotated for 10 biomarker classes. Biomarkers are tiny visual clues that reveal the presence of diabetic retinopathy. These biomarkers are divided into 6 pathological and 4 anatomical structures. The pathological structures include exudates, cotton wool spots, drusens, microaneurysms, hemorrhages, and neovessels. Whereas the anatomical structures include optic disc, optic cup, macula, and vessels. However, this dataset does not include the fundus images from the Mesidor, and they must be downloaded separately. MAPLES-DR dataset provides a Python package to load, export and preprocess the fundus images with their annotations from Mesidor dataset. It provides 2 GitHub repositories to perform automatic segmentation of the retinal vasculature and retinal lesions. Annotations were performed by 7 senior retinologists affiliated with 5 different hospitals, following the guidelines for Canadian teleophthalmology screening, which is closer to international standards. An AI model was used to pre-annotate segmentation maps. Later these pre-annotated maps were manually corrected and graded for diabetic retinopathy and macular edema. Here is an example of retinal vessel segmentation. The white denotes the AI pre-annotated vessel segments. Teal indicates the vessels that were manually added. And purple marks the annotations that were manually removed. The MAPLES-DR dataset is now a key asset for eye care research and diagnostics. In this section, I would like to share my learnings and experiences on working with MAPLES-DR dataset. For retinal blood vessel segmentation, I began with the classic U Net model from Monai library, because it is simple to use and works well on most of the tasks. I configured the U Net model with 5 encoder-decoder levels and 2 residual units per block. I trained the U Net model on full 1024 by 1024 images using DICE plus cross-entropy loss. Shown here are the inference and the validation loss curve. I soon realized that there is class imbalance, as vessels make only about 10 to 15% of the fundus image. So, I used DICE plus focal loss on full images for the U Net model. This gave better predictions by focusing more on the vessel region. And the red curve here shows the validation loss. I started training with full images, thinking that seeing the whole scan at once would yield the best results. Unfortunately, the GPU memory quickly became my enemy. Storing all those activation maps for backprop meant I could only squeeze in a batch size of 2. Training epochs crawled at a snail's pace. I switched tactics. I kept the same U Net parameters but moved to 256 by 256 patches. Suddenly, my batch size jumped to 4, because each crop's feature maps are 16 times smaller. Training speed up dramatically. Shown here are the inference for U Net model for patch-based training. The green curve represents the validation loss for U Net model using DICE plus focal loss for patches. But I began to wonder if there was an even better architecture that might give me richer representations without blowing my VRAM budget. That curiosity led me to SegResNet. I configured the SegResNet model with 4 down sampling levels and 3 up sampling levels. I started with 8 initial filters, half of U Nets, and doubled at each downsampling stage and kept the same patch size. This model captured vessel structures even more accurately and further reduced the validation loss because of its deeper architecture and residual connections. In summary, I experimented with different models and loss functions. The SegResNet model trained on patches using DICE plus focal loss performed better by detecting even the fine blood vessels and reduced validation loss. However, I would like to bring to your attention that if the network size and number of training iterations are increased, both U Net and SegResNet models with DICE plus focal loss have the potential to perform better on full images too. If you'd like to try it out yourself, I've shared the link to my GitHub repository with the full code. MAPLES DR dataset isn't just for performing segmentations. It can be used for classification tasks, to study disease progression, to develop explainable AI models for diabetic retinopathy screening, as an educational tool for ophthalmology training and much more. Like any dataset, MAPLES DR has limitations. It's relatively small, and there is a class imbalance of the biomarkers. This imbalance can lead to overfitting, if not carefully managed. However, techniques like data augmentation, transfer learning, and class weighting can help reduce these issues. Let's evaluate MAPLES DR using the FAIR principles. Is it findable? Yes, it has a DOI and clear documentation. Accessible? Yes, it is freely available under an open license. Interoperable? Yes, it has images in PNG format. Is it reusable? Yes, the annotations and methods are well documented. Overall, it scores well on FAIR evaluation. In summary, even though MAPLES DR is a small dataset, pixel-level expert annotations, open accessibility, ready-to-use Python package for loading and processing of data, clear structure with rich metadata, makes it a powerful dataset for explainable medical AI and easy to use. Well, if you're interested in medical AI, I highly recommend trying out MAPLES DR. You'll find links to the dataset, paper, and my training code in the description. I hope you found this informative. And I'd love to hear, what would you build with MAPLES DR? Drop a comment below.